the Epidemiology and Demography Department, we aim to understand and monitor the distribution and determinants of disease and health-related states at varying levels of resolution within populations. We do this primarily to provide evidence to tackle public health priorities in Kenya and more generally in sub-Saharan Africa. Since 2000, our program has supported a health and demographic surveillance system, conducting regular surveys to capture vital events and migration within a population of over 300,000 residents in Kilifi County. This platform has served as an epidemiological sampling frame that has helped us to tackle a range of priority questions, ranging from understanding the incidence of common childhood illnesses to estimating the effects of genetic risk factors on common infectious diseases, to understanding access to healthcare within populations, and estimating the impact of major public health interventions such as vaccines.
Here are some of the questions we've tackled by leveraging the Kilifi Health and Demographic Surveillance System over the past 5 years. We've continued to monitor the impact of 10-valent pneumococcal conjugate vaccine on invasive pneumococcal disease and pneumonia, finding no evidence of serotype replacement disease to date. We have also generated insights into the mechanisms underlying the protective effect of DAN2, which is a red cell polymorphism that confers 74% protection against all forms of severe malaria in homozygous individuals. In addition, we've also examined the implications of gestational age at antenatal care attendants on the successful implementation of a maternal respiratory syncytial virus vaccination program in Kenya, finding that 77% of pregnant women would be reached for vaccination within a gestational window of 28 to 32 weeks.
In Kenya, county hospitals are important for health service delivery, and they actually act as centers for provision of both primary health care and also they act as referral centers for large populations in Kenya. In 2013, we established the Clinical Information Network, which is a collaboration between the KEMRI-Wellcome Trust Research Program, the Kenya Pediatrics Association, Kenya's Ministry of Health, and the county hospitals. The aim for the Clinical Information Network is to support the use of routine clinical data for the improvement of care that is provided for hospitalized children, newborns, and more recently for severe acute respiratory illness surveillance amongst adults. So the network currently covers 21 county-level hospitals in 16 out of 47 counties in Kenya, spread over the geographical spread in Kenya. The network is now a multidisciplinary platform that is based on the learning health system principles, where clinical practice, research, and knowledge translation interact to result in continual improvement of care. Within the CIN, we send regular performance-based reports based on consensus-based indicators that is used to improve care, monitor disease outcomes, and also to monitor the epidemiology of diseases within the hospitals. Our work in the Clinical Information Network established the safety and feasibility of introducing RTSS malaria vaccine within routine settings, and that has led to the WHO recommendations for the broader use of the vaccine. We are also conducting a clinical trial within the Clinical Information Network, investigating different antibiotics and supportive care strategies for management of severe pneumonia in children. We are also setting up surveillance to monitor patterns of antimicrobial resistance and also to test different strategies for surveillance for AMR in Kenya using the network of hospitals. The Clinical Information Network also provide information to guide policy and practice both at the county level and at the national level in Kenya.
Over the last 5 years, we have increased our analytical and computational capacity to look at social and epidemiological determinants of health transitions. We've also worked on looking at access to health services and also vulnerabilities at fine scale. Some of the work that we have been able to do in these last 5 years is produce the first ever Pan-African database of health facilities across sub-Saharan Africa, sourcing documents from various sources across 50 countries to produce the first health facility database for the Pan-African countries. This platform has been used to look at several things, to look at access to immunization facilities. It has been used also to look at access to facilities for among children who have fever, so their probability of seeking care relative to where the facility is and where they live. More recently, during COVID, the database has also been used to look at access to facilities that are able to handle patients that have severe COVID. So looking at hospitals that have ICU units and high dependency units, and also access to equipment like ventilation facilities. The other work that we have focused on is looking at malaria epidemiology, which has been a mainstay of the population health unit. And this is work that has provided a quantitative framework to look at the link between malaria prevalence and severe, very severe life-threatening disease among African children. That work has changed the paradigm around our understanding of the relationship between malaria risk and severe outcomes.
The Ministry of Health has been monitoring daily cases of COVID-19 since the start of the pandemic. And by October 2021, we had over 250,000 confirmed cases and above 5,000 deaths reported across the 4 waves of the pandemic that the country has experienced. Based on the setup of the infrastructure that we have here at the program, as well as the capacity building and the networks that we have, we were able to work with the Ministry of Health and design a program of studies to help monitor the cause of the pandemic. And we were actually able to design studies that cut across different target populations of frontline workers, but also population-based surveys. And this was made possible due to the development of an in-house validated ELISA that was developed with our collaborators at Mount Sinai in the US. And when we were actually able to do this work, part of the main data that came out of it was the fact that we were actually able to demonstrate for the first time that the pandemic had gone beyond the active and confirmed cases that were being reported by the Ministry of Health. And these levels have actually exceeded what has been reported in Europe and in the US at the time of which we had the study. And it's quite remarkable that we had such high seroprevalences, yet the morbidity and mortality that we experienced was apparently a lot lower than the developed countries. And this data has actually been quite useful because it has fed into transmission dynamic models that were developed to help the Ministry of Health forecast the development and the progression of the pandemic, which definitely had an effect on public health intervention and control.